Okay. Good afternoon. Oh, is it good morning or good afternoon? I'm not sure. Still morning. It's a long day. Good morning, everyone. This is Andrew Siegel, the Director of the Division of Long-Term Care. We have, I see quite a number of people, attendees on the webinar, and we thank those of you who could make it today in person. We're happy you could all gather here today. This is the fourth in a series of meetings that you all know we've been having, in which we hope to continue the conversation and to engage with all the stakeholders on the future of integrated care in New York State and kind of begin envisioning together collaboratively what the best vehicle is to deliver the care that's necessary, that's both high in quality and that is cost effective. So as you know, we are convening these sessions together, feedback from our MLTC, MAP, FIDA, and PACE plans, as well as providers, members, and stakeholders. And to that end, I can say definitively that we've been very, very happy with the amount of engagement we've had so far, and we appreciate everyone continuing to engage. Our kickoff meeting in July had about 80 people make the trip to New York to attend in person, and the webinar had 376 callers. So a little bit less today, but we continue to appreciate all the engagement we've had during the meetings and after the meetings as well. We've maintained a pretty high level of participation and a lot of feedback since the last meeting as well. So the whole purpose of this planning process, as you know, is to begin to plan and to prepare for the complexities that we see in the dual population of providing high quality, comprehensive care to our highest cost, highest needs individuals in Medicare and Medicaid. And we think by having this approach, we can really move the needle and create maximum impact on health outcomes. And we've heard a lot of great success stories for this population and other programs, and we think there continues to be a value-based argument for outcomes and for cost efficiency, and as well as overall satisfaction. And we're hoping to achieve those and whatever the future vision will be. As you know, managing and coordinating the delivery of care for dual eligibles has become a central focus of the state health of kind of the federal health care reforms too. And I think there's a recognition in all the great work that we do at the state level and sharing in the cost savings and with the feds and on the Medicare side. And this population, which really accounts for a disproportionate share of long-term care costs, it represents some of the most vulnerable folks confronting both economic and health complexities, and so continues to be a central focus of the state's reform efforts and thinking about next steps and engagement and planning for what the future model looks like. In addition, there are challenges that we are faced in efforts to best serve this population. As you all know and experience every day in the work that you do, and there are some of the topics that we've already covered and will continue to talk about, which include retaining sufficient networks statewide, creating and supporting incentives to provide integrative care, offering the highest quality of care that is both person-centered and community-based, which is something we all strive to do and every day in our work, organizing and maintaining necessary resources to deliver care, workforce challenges we all face, and creating quality metrics and performance-based incentives for an integrated product that are really all-inclusive and that take into account all aspects of the care model. We really think that better coordination of care, I think, should be clear through today's conversation and through this whole stakeholder approach and the amount of time that we put into this, that we think better coordination of care and services between Medicare and Medicaid holds significant promise in terms of being able to improve the lives of millions of New Yorkers. And we've seen that through some of our integrated models already in the state and our FIDA demonstration. And this is, that's paramount as to why we continue to go through this process. So I'd like to thank you all just very much again for being here today and for attending via our webinar or in person. I'd like to welcome all of our managed care plans and participating providers and stakeholders who are here in person or on the phone. I'd also like to thank our partners in integration from CMS, Melissa Seeley, Toby Oliver, and Jessica May. Thank you so much for being here, Melissa. And our team from DOH who's here today, Joe Shunk, Alyssa Helbrin, Renee Labritz, Madeline Royale, Patrick Cuccinelli, and Francis Nass, and also the folks from the Department of Finance who have come here, Jack Patera and Renetta Robinson and Rob Lloyd. We appreciate you being here today as well. So without further ado, we will proceed with the slide deck. I guess is that what's next on the agenda, Joe? Okay. Or the overview of the process? Okay. Yeah. Should I do that? So, okay, so today we have our meeting materials. We're going to further discuss draft language. We have various topics we're going to cover today, including payment and rate considerations, outreach, education, and engagement of participants and providers. We're going to have a small discussion about MCO plan requirements and qualifications. And then we're going to end with a discussion on enrollment. We will have a follow-up period for questions, and we will have follow-up. We expect to have it after the meeting in terms of, getting further feedback. If folks don't have an opportunity to participate on the phone today, they can always write in to us or to the DML, and we will continue to evaluate all the input that we receive from today's webinar and on an ongoing basis. And so that will be the process today. And again, we thank finance folks for being here and having a discussion.
So the next spot that we're going to do, thank you, Andrew. Madeline Royal is just going to go over an overview of the sessions that we had last month, October 16th, and some of the feedback that we received where many people have submitted their questions for the response to the BML.
Good morning. Can everybody hear me okay? Okay. All right. So we've been getting some really great feedback, and we do want to encourage you to continue to submit your written feedback to the Future of Integrated Care BML, and this is a platform to get specific suggestions to us and that we can, review and keep an eye on. As you know, with each session, the department has distributed a series of questions relative to the topics to be discussed. That was included in the Excel template that we sent out. Topics discussed in our last meeting held October 16th were participant rights and protections, marketing rules and flexibility, quality standards and measures, and the provider network. So for provider rights and protections sections, generally commenters agreed with and were supportive of the discussion draft language that we had distributed for that. However, there was a consistency in suggestions of a more cohesive approach among all parties, including grievance and appeal processes that would include Maximus, the plans, and administrative law judges. Comments also suggested adding language to annual member rights notices that speak to sexual orientation, gender identity, and a statement for people with cognitive limitations to have rights for additional time for their appointments. Stakeholders agreed with requirements maintaining a participant advisory committee. However, they would like to see some more flexibility in the time requirement and suggested perhaps meeting semi-annually. So on to marketing rules and flexibility, comments reflected a response suggesting a more inclusive approach for cultural awareness and diversity to marketing materials. For example, many of you felt as though marketing materials should be sensitive to cultural or language differences, especially for individuals whose language was not, English was not their primary language. Support of a more united and streamlined state and federal review and approval process for marketing materials. So in other words, we want to see one review by both parties, as well as a more defined approval timeline for this process. Last to the marketing section, commenters supported using translation requirements similar to the newly implemented FIDA translation requirements for FIDA primary. With regards to quality standards and measures, commenters recommended that quality assurance requirements be aligned with the requirements of CBP that are already in place. Concerns that were voiced about the high volume of reporting and quality measures encouraged DOH and CMS to develop a set of quality measures that enable plans to focus their efforts on achieving sustainable quality improvement. There were also recommendations of consolidation of duplicative DOH and CMS measures, and we received several recommendations that enhance administrative efficiencies between Medicare and Medicaid reporting requirements, 3 of which included a standardized QIP and CCIP, an integrated reporting process between CMS and DOH, and consolidation of the DOH and CMS satisfaction surveys. So now, this final topic was on provider network. So I just asked, just bear with me a few minutes, as this was by far the most dense. So we asked a series of questions that solicited feedback around language relative to provider network standards, rules around provider choice, access to out-of-network providers, and travel standards. So there was a consensus that overall agreed with the draft discussion. However, commenters recommended flexibility on minimum network standard requirements based on population being serviced, population size, the county, and provider availability. Commenters also recommended inclusion of telehealth services in provider network requirements and greater consistency between Medicaid and Medicare, the requirements around that. Also recommended was implementing a more streamlined provider network submission opposed to the separate Medicare and Medicaid submissions, as well as relief for provider directory and collection requirements currently existing in FIDA. With regard to provider training, commenters cautioned that training requirements for providers might turn providers away, similar to how it did with the original provider training requirements in FIDA, and it contributed to a low provider engagement participation in FIDA, so we're looking at that. We were urged to provide regulatory relief for home health agencies when contracting with fully integrated managed care plans. And lastly, we were advised that DOH and CMS solicit feedback directly from the provider representatives and, for their input and the nature of the requirements to complete provider training. So this concludes my summary of the comments from October 16th. We really just thank you all for your thoughtful and insightful comments, and just really want to encourage you to continue to submit to the DML. So without further ado, we have Department of Finance.
We have Jessica on the phone from CMS.
And, well, yeah.
Renee and Jack here, and Renee as well on the finance side.
Yeah, I guess before I hand it over to Jessica, just like I say, you'll notice in the finance section, all of our points are ending with question marks, and there's that's intentional. You know, we are here today really to hopefully engage the community, the providers and plans in a dialogue as to, you know, what you're seeing in the finance section, what would be helpful, what is difficult, and hopefully we can sort of all work through those issues together and have a meaningful discussion on the matter. So I think we can turn it over to Jessica May at CMS first to talk about some of the payment and rate considerations for Medicare.
Great. Hi, everyone. This is Jessica May from CMS. I'm dialing in remotely, so I want to make sure that everyone can hear me all right.
Yep, we can hear you.
Okay, great, thanks. And just as some background, I work in Medicare Medicaid Coordination Office at CMS and primarily focus on rate setting and finance issues, both related to the financial alignment demonstration as well as more broadly for dual eligible beneficiaries across Medicare and Medicaid. So on the slide deck, you'll see 3 kind of relatively high-level questions that we put together pertaining to the Medicare side of the rates that we wanted to put on the table to get input on this morning. One of the accompanying documents that you should have is a chart that lays out at a high level kind of the rate parameters across Medicare Parts A and B, Medicare Part D, and Medicaid, just to kind of put on paper what some of the most significant differences in how we set rates or finance the programs are, since I know a lot of the discussion we've at least had on the Medicare side relates to some of those differences. I'm not going to go through that document line by line, so obviously happy to take any questions that folks have on that. But thought we could get started with kind of, the first question on the slide and kind of talk about that, but obviously any other, input on anything related to Medicare rates and financing, please jump in. And Francis and others in the room, I don't know if it would be helpful for folks when they provide input to identify kind of a name and organization, just since I don't know who's there in person in the room.
Gotcha. Okay, so anyone that when they have a question or comment, just please make sure you say your name and what agency you're from or plan, or if you're a stakeholder, and so Jessica can know.
Great, that would be helpful. So I'll just kind of start with this first question. This is a very big one, but when we're thinking about how various options for structuring the Medicare rates, one of the big differences between FIDA and what we see in kind of MAP combined with traditional MA plans is kind of how the rates are set. And so in FIDA, CMS sets the rates. There are a number of parameters that we use. It's built off of Medicare fee-for-service costs and Medicare Advantage rates, but it's a plan set by CMS that is specific to each county. Whereas the more traditional Medicare Advantage structure has benchmarks or projected costs that plans bid against, and it's really a plan-specific rates versus rates set by CMS. I think that's the first kind of high-level question we wanted to see what folks' thoughts are on that kind of general rate setting parameter and some of the considerations we all should be thinking about in that regard.
So this is David Wagner from Elder Plan. We have both a Medicare contract that we do bid on, and we have as well a FIDA product. And our MAP product is in our contract with the current bid structure. So I guess we have experience on both sides. So I would actually ask a couple of questions before I guess my comment or my suggestion would be, which is first, the bid process takes into account sort of where the current state of or the prior year's costs and information that rolls through for a prior period, and then you project out to the bid year based off of those costs. What would be the process for an entire new program to start bidding? That would be sort of my first question. Second question alongside that would be, is this going to be an exclusive contract the way that FIDA is, where you don't have other types of products within? Because when you bid and you have other products within, there's sort of a lot of information that goes one product within another and another product, and it all rolls up into one bid. If this is one product standalone on its own, it might be a little bit different than if you have other products within there. And lastly, is this, because I know I've posed the question in the past, but I haven't really gotten an answer. Is this going to be a program that is a three-way contract with the state, or is it a separate, two separate contracts the way MAP is, where you have a contract with the state and you have a contract with CMS? And I ask that question because the bid process is one of the plan with CMS, and there's no involvement from the DOH side. And I think that actually does play into, within the way that the contract is written, if we were to go over to a bid process. So I asked a lot of questions there, but.
Sure, and I'll invite others in the room to jump in as well, because I think I have probably some the high-level answers to some of those, but I think many of those kind of get at questions that we're still working through as part of the process about figuring out kind of what should this look like. So regarding your first question, at this point at least, I think if we were to envision, if we kind of determined collectively that going in the direction on the Medicare side of, bidding and kind of more similar to what happens in traditional Medicare Advantage. Just given the infrastructure and the kind of time that it's taken to kind of get that in place more generally for MA, I don't know that we had envisioned kind of a separate setting of benchmarks or a separate bidding process different from what happens in the Medicare Advantage world. I think if there was interest in going in that direction, there's certainly advantages and disadvantages, but advantages in terms of timing and resources to using or building upon the existing structure. On your second and third questions around, whether we were envisioning it being kind of separate contracts or kind of folded in with other contracts that you might hold in the Medicare world, and whether this would be a three-way contract like currently exists in FIDA, or something more similar to kind of what happens in the FIDA SNP world, where there are separate contracts with the state and with CMS. Others in the room, please weigh in, but my understanding is, that's still kind of part of what we're trying to think through here, and we haven't made a decision on that at this point.
David, do you see pros and cons?
I do.
You want to talk about some of those? See if there's any reactions.
Like I said, we do the bid process, and there, as was said on the phone, there are some positives and negatives there, and my recommendation actually would be probably to lean towards the bidding process, because that sort of brings you into really what Medicare Advantage and what's done around the country and what's generally done. But while saying that, I think a three-way contract complicates it. I really do. I think that the way that FIDA is set up, the MAP, the FIDE SNP is set up right now with separate contracts, lends you to be able to go through the bidding process in the traditional Medicare Advantage bidding process way. With the three-way contract, if there are pieces to the Medicaid side that overlap with the Medicare side, it's going to be very hard to parse that out, especially if you have it within a contract with other products that might layer itself in there, which also I think is not a bad idea. I don't think right now FIDA is a separate contract because it's a three-way contract. I think if you had it as two separate contracts, with one with CMS and one with the state, you might be able to bring other products in, which actually can help the bidding process in itself. So that would be a recommendation. I don't know about this.
Do others have any thoughts about that? Thank you, David. That's very helpful.
So this is Melissa Seeley from CMS. Just to kind of ask for a little bit more clarification, would you suggest that there be that the future of integrated care products be folded into an existing contract number like you have with your other D-SNP products? Is that?
Well, not all plans have other contracts, but right now we have a separate contract for FIDA, which if and when FIDA ceases to exist, I would imagine that contract either shuts or closes, and then the product, whatever we call future of integrated care, will need to either be layered into a current contract or get its own contract. But within that own contract, you can make that contract one of two ways. You can make it the way it currently stands, and if by chance, so Elder Plan, I can only speak for ourselves, Elder Plan has a contract. So we might have the option of taking future of integrated care and putting it into our current contract, but then that would be one complete bid process. you know, takes time, takes administrative costs, takes a lot of, you know, a lot of pieces to it. There's a lot of pieces to it. So if we had the ability to layer it in, you might want to do it that way. You might not, because there are other pieces that might complicate it when you have a straight Medicare Advantage and you have a, you know, you have a D-SNP or you have, you know, other products within your contract. It also lends to, I know this is not a quality conversation, but it does lend itself, when you talk about contract, to stars and what your decisions are on the star basis if you layer it into a current contract with other products, and or you have it as a separate contract because, and don't let other products in. So it's not just a finance question or a bid question. It actually is something that I brought up, I think even at the first meeting of this, because it's so basic to know whether this is a three-way contract, a separate contract, if you're going to be bidding or if you're not going to be bidding. So.
Thanks, and I think there's also a network impact in the way that
Sure,
you that
absolutely.
separately or through one contract.
For sure. That's why it layers into all of those things that was, you know, where you started.
So, David, with that proposal, are you precluding any idea of a bundle payment?
Not necessarily. I didn't really actually propose anything. I just threw it out there as a question to everyone here and to the department, because it really is a very high-level basic question that has to be answered, because as you get into a lot of this, it affects so many different pieces of what we're trying to do here.
You see two separate contracting processes for one single bundle payment?
Sure, why not? Yeah. I don't think you're precluded from that.
But wouldn't that complicate the delivery of the care and the product?
It could, but again, how are you structuring your bundled payment, and with whom?
That's true.
It's not just about the contract and the bid. It's about who are you bundling your payment with,
right,
and how do you structure the bundle.
Right.
It doesn't necessarily preclude you from doing it that way.
But would that makes things like streamlining appeals, I think it would complicate all the other mechanisms by having two separate contracts.
We do it now, MAP.
Right.
Doesn't complicate things at all.
No, you're right.
FIDE is much more complicated than MAP is.
So would folks like to see more of kind of like a road? Is it something that would merit some interest in seeing what this would look like, or kind of going down that road of looking at some of the pros and cons, at least, of, you know, bid, not bid, a three-way contract, or a three-way agreement, and trying to kind of parse that out? I mean, I'd be interested in hearing what others, I know we may not have the time now, or if others don't feel comfortable on the phone, just hearing from you about kind of what your thoughts are on this, whether you're kind of in agreement with David or disagree, or you have other thoughts about it. I think that would be helpful for us. Yes, Judy?
I think if it's laid out, perhaps the different contract processes that David described, if they're laid out, I think the group stakeholders can have more of a, you know, input on which process might make more sense.
Mm-hmm.
So it's the current processes and then what the future looks like.
Well, you might want to do current process in MAP, which is one, current process in FIDE, a three-way contract in another, pros and cons in each,
exactly.
and then try to do something.
There is a document that I believe was circulated that sort of lays out a lot of what you're talking about.
Did everyone get this document that we're referring to? The title is Potential Payment Parameters for Discussion Purposes Only.
I'm not sure if there's any particular areas you're looking for elaboration or more detail on.
The bid process. The bid piece is a big piece of it. The bid versus not bid is a question in here, but it doesn't talk about three-way contract versus a separate contract.
Is there another comment in the back?
Yeah, my name is Sherry Wolfgang. I'm from a PACE program here in Schenectady as a senior here. I'm kind of new to the payment and rate setting discussions, but wondering if part of this discussion is looking at or getting more clarification as to the methodology of the Medicare savings piece of how the rate is calculated, giving us a way to compare pros and cons.
Hi, this is Jessica Mancini. I think I heard your question. So I think that was getting at how we are evaluating or how we would approach kind of the savings that's currently built into the FIDA rates, or are you, or kind of on the PACE side? I'm not sure I heard your question fully.
Looking for sort of clarification to the methodology used as they do our rates, that there's that piece of the Medicare savings or sort of clawback
Are you referring to FIDA?
case, which is a three-way contract.
We were having a little conversation over here on the side. The question that we were trying to weigh back and forth is administrative hassle for doing separate bids and two separate contracts versus streamlining things together. I think one of the lessons we've learned from FIDA is we've had a lot of hassle with a lot of the nuances of various things that were put in, whether it's reporting, whether it was the certain meetings, whether it was certain administrative functions. There were certain benefits by having everything streamlined. So I'm not saying there's no bid. There's advantages of bid that you also invent your own product a little bit more. You have that advantage there. But the challenge of having more administration versus ultimately we're trying to come up with a plan that will improve outcomes and cost less money. From what I've been hearing in previous meetings and even some of these processes, we need to find ways to bring overall administrative costs down if we're going to see any sort of savings. So if there's anything that's going to cause more administrative hassle, I'm hearing a lot of things that sound like great ideas, but there's a cost to that. You know, we all want the most fancy car, but we don't necessarily need it to get to work.
But if you have a current bid, then it's no more work.
Sure it is.
It's not much.
It's the bid versus the contract, the administrative hassle. The bid itself is right. The bid itself might be incredibly small. It's still the extra experience of the product. It's still you're separating, trying to a little bit of the hassle because you have the overlapping Medicaid and Medicare benefits. While for D-SNPs you don't really have that as much.
You have that right now in MAP, but you did bring up a good point in the fact I would put this in the positive on the bid side, which is you can create your own product with supplemental benefits. And right now, you know, you meet with a provider or you meet with, you know, a group, they get all FIDA plans the same, you get the same benefits, you're pretty much the same. So what is the, you know, there's got to be some type of, or I would imagine, you would want some type of competitiveness in it. So a member actually has something to look at to say, oh, what benefits am I getting from this plan? What about this plan? What about this plan? You don't get that in the current FIDA structure. But in the bid process, you have all these other pieces to it that layer in that give either an advantage to one or maybe not such an advantage to another. It also can lead to a plan being able to deal with its financial bottom line better because if you're not happy with, you know, where your financial bottom line is 1 year and it fits within the bid structure, you eliminate certain benefits. You might not be able to grow as much. You might even lose membership, but you can control your bottom line a little bit better than when you don't have the ability because FIDA is, you know,
but that would also make the state has to agree that certain benefits are not going to be mandatory.
Only if it's a three-way contract.
Either way. Even if it's a three-way contract or separately, if they understand that if we're going to have that flexibility, there has to be the ability to carve or reduce or increase benefits.
Well, not just a severable issue from two contracts versus a single.
It's not just the issue of what's mandatory or not, it's also like not prohibiting us from doing certain things too.
Right. But that's what MAP is right now.
Right.
I mean, there is a current product that has all of what I'm talking about on the bid side.
But on the bid side, it focuses on the Medicare component, and you have to like incorporate the Medicaid. If this is an integrated product, the bid would have to like roll that in.
Integrated product.
No, I understand, but they don't consider all of the Medicaid carve-outs. You would have to roll that in. So I mean, I agree with Steve that it would be administratively burdensome. I mean, they would obviously have to lay it out, but.
So, just to get clear, so David's assertion is there's a bit of flexibility right in the bid process where you can control your bottom line costs and you can create kind of sort of a little bit, and you have product diversification in terms of differentiating from the plan member's perspective, right? But then there's the admin cost, right? So how do we all value the admin costs associated with, you know, that extra bidding process, and, you know, does that outweigh any savings that you might be able to generate from managing the bottom line. Do others have thoughts on this?
Well, okay, we'd also need to encourage the state not to do things like in the past to say, well, you can't give out extra benefits. And so the plans not only is the floor a little different, but then in some ways the ceiling's a little different, so that we're not prohibited from doing a number of activities, so that the product diversification can be actually very real for the consumer.
Okay. So Matt's suggesting that, we should take into consideration what's mandated and what's not, right?
Right. And what's prohibited.
And what's prohibited, okay.
I think my comment was not really specific to the bid. I think even to the three-way contract versus two separate contracts, every little component, there's administrative expenses, whether it means having participant meetings, whether it means just focusing and working with contracts with, two separate contracts is additional burdens for each of these. Every single thing, I think the goal here, I think we should be looking at simplifying things to make it easier for the plan, the state, CMS, and the member. By simplicity will make things more transparent for them as well.
So on that note, what comes clear is that administration simplification is something that folks would like to see. And I think we can have that as a tenet as we look to, some of it maybe be helpful to kind of bucket some of these things that folks really want to keep, I think are part of an ongoing dialogue, and that might be one of them. Just kind of big headline themes and how we kind of consider and continue to move the conversation forward. In my mind, that's definitely one of them.
Jessica?
Should we move?
Are you still there?
Should we move to the next question?
Yep, sorry, this is Jessica. I can hear folks that are close to the speaker, but not everyone in the room, so my apologies.
Okay.
And I think a lot of what we was just addressed kind of got at that second question around supplemental benefits, and kind of there's obviously a lot more in the weeds there about kind of how at least the current bidding structure works and what the benchmarks are, but that that explicit ability to use rebate dollars kind of there certainly is different in MAP and MA generally right now as compared to FIDA. The last question that we had on our list that we wanted to make sure we had an opportunity to get input on today is one that I know has been a topic of discussion as pertains to FIDA since probably the beginning of the demonstration around risk adjustment and frailty. And I think we certainly have another perspective from the plan side about the importance of using the frailty adjustment where possible if we were to stick with kind of the current risk adjustment model. But wanted to make sure that we had an opportunity to get kind of any other input on that issue in particular, or risk adjustment more generally before we move on to kind of the Medicaid side of things.
But I don't think you're obviously going to hear any pushback from anybody that we don't think the frailty factor should be in there. But I think you get complete agreement in that. But I've been part of, and I know certain other plans in the room have been part of on a national sort of debate over whether, and through our associations on the Medicare side with CMS, over the fact that the frailty factor should not be applied the way it's applied, to a specific product. If a member, doesn't matter what product they're in, whether it's D-SNP or whether it's, whatever product it is, if they meet the qualifications for frailty, it should be on a member-by-member basis. If you meet the qualifications for frailty factor, then you should be receiving, the plan should be receiving the frailty factor attached to that member. Because in general, risk scores on the Medicare side are member-by-member anyway. So our argument has been, through our associations on, with CMS, and there has been quite a debate on it, that a member, if they qualify, why if you qualify in MAP? Because MAP does have a frailty factor, adjustment within the MAP product. If you're the exact same member in D-SNP, why are you not eligible for frailty factor? If you're eligible for frailty, you're eligible for frailty. FIDA too, same thing. If a member is eligible, the plan should receive the frailty factor. So,
in that discussion with CMS, have you, and I don't know in the weeds of this, but have you had the discussion about where CMS does and doesn't have the legal authority to apply the frailty adjustment?
I don't know about the legal authority to apply it or not to apply it. This is more of a conceptual thought conversation on it, because there's no question things would have to be changed from a legal basis, but it's really conceptually, you know, if a member is eligible in one product, why does the plan have to have that member move into that product to receive the frailty factor? They're eligible, they're eligible.
Sure. Yeah, and I think that gets at what, you know, the kind of what frailty is intended to reflect, and that is kind of the, you know, the residual or what's not explained in terms of anticipated costs by the risk adjustment model. One thing that I just wanted to note as kind of relates to what you just raised, but also kind of some of the, you know, broader discussion about the population to be considered as part of kind of moving forward is, at least within the current what's currently available for frailty, and folks that know this from their plans can correct me if I'm wrong, but you know, there needs to be a certain concentration of individuals that meet the frailty criteria within a plan for a plan to kind of meet the level of frailty to add that to payment. So I think that's something to think about in the context of both what you had just raised about an individual kind of level of frailty, as well as, you know, if there's a material kind of number of more kind of community well, as we might refer to them, individuals that kind of are part of a target population, what that means in terms of a plan's ability to get the frailty adjustment under the current frailty parameters.
I'm pretty sure that the major criteria is over 65 and that you would need at least, I think it's 4 or 6 ADLs, where if you look at the population that's in FIDA now, that's in MAP, or anyone who's going to qualify for a CBLTC service, generally is going to qualify for the frailty factors. Not always. I might have missed a couple of other qualifications, but those are the major pieces to it.
Yeah, I think it just gets to kind of, it looks at the proportion of respondents in each plan that have those ADL limitations, and that there's a calculation behind that. That has to kind of get to a certain level that exceeds the average level of frailty for PACE plans. And so my only point was if you have a lot of members or a lot of respondents who don't have ADL limitations, then that kind of can change the calculation and I think the potential to get frailty.
Okay, basically, David, you're saying that there's very little gap between the state's requirements for them to qualify this plan, and almost anybody the state requires should be under the frailty factor, should have a frailty.
If you include well duals, if you include well duals, right? People who aren't eligible for frailty assistance.
Yeah, but it has to be dual. I mean, the partial duals, you mean?
Right, and then you also have the under 65 community who's not eligible either. So it's not 100% that it matches up, but I'm saying that generally most of the members who might sit in an MLTCP right now are going to be eligible for the frailty factor if they were to choose to go into a product.
Okay, but let's pull back a second. So you're talking about a technical definition of the frailty factor, but in essence you're saying, or I mean, I think we're all saying is that anybody who's in requires LTSS services does need an extra boost. Regarding call frailty factor, call it whatever you want, call integrated plan boost, whatever you want, they need a boost on their medical, on the Medicare expenses as well. So you can move away from the named frailty factor, so to speak, for this discussion. But the problem is that's where I think what you're saying is that current Medicare rate would not adequately fund this type of population.
What I'm saying is the reason when it comes to CMS, you need to work within their parameters of adjustment. Frailty factor is that adjustment, so that's why we just use that term. But to your point, 100%, you're right on target. Most of these members are going to need, from the Medicare side, a boost to the risk score, which is what the frailty factor adds.
But you're missing that gap of people who are not getting that boost, that need that boost as well.
Right.
because they are for LTSS population.
There was a comment on this that came in from one of the webinar listeners, John Shaw. It says, the majority of home and community-based services and support time is provided by informal family caregivers. This is a lower-cost alternative to paid care. Education and support of the informal caregiver is key to member health. Should this education and support be a formal supplemental benefit considered transparently? At a minimum, access to an informal caregiver versus living alone should be a consideration of risk adjusting for frailty.
What do folks think about that?
CMS is going to change their criteria for that.
Well, CMS, yeah, I'll let them comment.
I'm sorry, Jessica, I'm happy to jump in. I wasn't sure if that's what you were asking though.
Yeah, if you have a comment, go ahead. I was just reading what one of the,
sure.
Yeah, one of the callers.
So I think just as context, the structure we have right now for frailty and for risk adjustment more generally is kind of a regression model where various demographic and health status factors and then ADL limitations are regressed against cost to come up with either risk adjustment or frailty factors that do the best job of explaining the projected cost for beneficiaries. So there's always certainly opportunity to think about kind of what other factors, might be something that kind of there's interest in discussion around consideration of in the risk model. It just, we have a challenge of this is a risk model that we use kind of across the board for every MA beneficiary in the country, and whether there's kind of sufficient, one of the questions is always is kind of, is there sufficient and, robust enough data on a particular, criteria to kind of include in and be valid for the purposes of a regression model and kind of risk adjustment. That's kind of getting into the weeds too much. But that's just something that we always tend to think about when there are kind of other factors that we might want to explore further in terms of whether they better predict costs in the risk adjustment system. And in terms of just kind of the additional benefits, yeah, I think a lot of that depends on kind of how the contract is structured. Obviously, in the Medicare Advantage world, when we think about supplemental benefits, there's kind of a very limited defined number of services that fall under that, under kind of the MA regulations. But that's not to say that those are not services that planning can provide or would support providing. It's just kind of thinking through kind of what's the appropriate vehicle and the authority for providing that sort of thing.
I mean, I think there might, thank you, Jessica. I think there might be a broader question within this question here, right, online, which is, the role of caregiver support in all of our long-term care models, and are there unused home care, caregiver support that we can better account for in a model going forward, and how do we do that, and what role does that play, and how, we look at staffing cases and how the personal care benefit. I don't know if folks want to explore that in another conversation. That might be something interesting to talk about, or untap caregiver support.
I'm just not sure how.
Not necessarily related to frailty.
No, forget frailty. Yeah. We're talking about more on the Medicare side. Even that comment was more on the Medicare side. I'm not sure how the caregiver support in any way would adjust up or down the mechanisms for risk score adjustment member by member within the Medicare system. The Medicare system risk score adjusts by diagnoses, by submission of encounter data, and by certain very specific criteria that create the buildup of a risk score. If an individual has whatever they have, I don't know, whatever factor that they have, I don't see how a caregiver is going to change whether a person has EHS or not, or whatever they might have. That risk adjustment to the Medicare side is not really adjusted by what the caregiver can or cannot do.
Okay. Let's continue to move on. Is this the third bullet point? Jessica, do you want to keep going? Or did we cover that already? We covered it. Okay.
I think we covered it.
Slide 6, we're on the Medicaid side now.
All right. So this first bullet point here is a bit loaded, so I'm probably setting myself up here. But part of the question here deals with adequacy of our rate structures, and I think you know, I think when it comes to sort of the medical or the long-term care service and support components of the rates, we're using our operating reports and any fee-for-service data, and you know, I think you know we like to think we have a fairly decent handle on that. I think the issues really become in you know program design and structure for administrative and care management components of rates, and you know I think to the extent that, you know, we believe that robust care management is actually driving quality and is driving efficiency, obviously it's in the department's best interest to be compensating for that appropriately. So, you know, the question really becomes then when we're looking at these different program design options, you know, what design options really work for the future of integrated care in New York. I think a lot of the care management is really sort of provided by giving people the opportunities to access sort of long-term care service and support that we think will eventually and should be able to drive savings and efficiencies in the acute care arena. And so I think when we look at our rate structures and we look at, you know, how we are bifurcating or not, or combining and streamlining the systems and the contracts and the reimbursement, that sort of becomes a question as to what is the appropriate approach. I know that we spoke earlier, some was mentioning about Medicare savings percentages. I'm not that familiar with the pace setting program, but I know, you know, we're doing that on the FIDA side, and you know that is sort of a representation of potential savings through care management of integrated care. But you know, where do you put those investment dollars, and how do you see those coming in as savings in order to, you know, essentially fund that care management and administration appropriately?
So, are we in this conversation going under the current contract that's in place versus what's just been put out there? Because the reimbursement system for that has not really been dealt with. So, when we talk about what's the next piece of future integrated, the Medicaid piece, I would assume we're talking about where we are today in reimbursement.
I think we would talk about where we are today and how that could be potentially improved for future integrated products.
But is it the department's idea right now? This past year, the department has aligned the programs all within one rate bill, and then
to an extent, the long-term care service and support base has been,
which is by far the most significant piece of rate.
By far the most significant piece, and that's why I'm saying when it comes to the sort of the medical components and long-term care service and support specifically, I think there is sort of an alignment and a structure there. I think it's the additional services. I think it's the care management that's sort of outside of that and is product dependent.
But the care management is all going to depend on what you require within ratios, because we need to increase our staffing if you contract the requirements on ratios. So if you put out there a contract with a ratio that is not what the current plans have, you're going to have to pay for it, and you're going to have to increase the capitation. So currently, right now, I think FIDA is required at 1 to 100, something like that. What's the requirement?
There's no ratio.
There's no specific ratio, but okay. If there is a requirement that, for example, was just put into the new contract at 1 to 75 care management ratio, and the average plan out there has an average ratio, which is what's calculated in the current rate, how it rolls 2 years forward and rolls within the rate, at 1 to 125, 1 to 150, whatever the current average is, you're gonna have to pay double for care management if you're gonna layer in a different ratio.
And add in the multiple calls now needed, so also
Correct.
actual changes to the needed care management.
Perfect.
It seems like there's a little bit of a disconnect between this sort of, we have a large deficit, we have to sort of start thinking about ways to attack that, and then loading on a contract with a lot of new requirements that will have a huge impact on not just care management, but administrative as well. When you were giving the updates in the last meeting, you discussed how even some of the requirements for providers were, they had negative impacts before on networks. Now even this new contract brings in new requirements for providers about having to take certain pre-approved trainings and stuff. I can't even beg podiatrists to join my plan. Like, forget about now. I'm like, oh, and by the way, you have to tick these things off. And that is a more of an administrative burden in addition to that. Even the discharge planning that's going into this, things like if we need visits, going to hospitals and that's fine. I get why we want to do that, but all of that costs significant dollars. So there's definitely, again, seems to be this disconnect between the programmatic side and the financial side.
And that's why I started with what contract are we starting with?
Yeah.
Are we starting with the current contract that we're all living and breathing, or this new proposed thing that's going to cost a lot of additional funding from this department?
I'm Emily from the Medicare Rights Center, consumer advocate, and I just wanted to tack on to those things. I think we do need to have a more realistic idea of what it takes to be a care manager in long-term care. Do they even have enough hours in the day to call everyone that they need to call and manage what they need to manage? And that's something that we hear from, our work group members as well, who are people with long-term care. And also having a better understanding and breakdown of where risk adjustment comes from would be interesting, considering we do hear from folks about how their care plans aren't completely transparent to them. So if we're relying on care plans and all these, how does it affect the consumer, and is it actually speaking to what the consumer's needs are, I think also needs to be explored further. So that's like a lower level thing. But as far as care management goes, we definitely need to take a step back and see if we are implementing ratios and all these other things, what should the ratio be and how much can a person handle if they're working with somebody who needs care, can they adequately do that?
But whatever is implemented has to be paid for. That's the point.
And that's what we're hearing when you were giving the review of all the previous meetings. All I heard was dollar signs. This costs more money. This costs more money. This costs more money. And if we're trying to have this plan, the whole point was to bring efficiency and bring down costs. Well, either you have financial efficiencies or you have improved care. It's very hard to get both of them. Everything to get your most expensive car, but you don't need that. People can be healthier with good, adequate care. The goal is to reduce costs. Let's focus on reducing costs. The goal is to make everybody healthier. There's a price tag to it, but no, there's a price tag. You can't get both.
I also want to comment that I agree with everything that's being said with care management, but with regard to some of the benefits that have no limitations, such as transportation, we're not being compensated, the FIDA plans are not being compensated accordingly with the lack of criteria and, a limitation. Obviously, we want to keep the participants safe in the community and allow them to access community resources, et cetera. But, some of the requests you don't have a leg to stand on when you say, well, does this meet the definition of a community resource? I'm all in favor of, getting the member, the psychosocial needs and whatever it is, but it needs to support the care plan and keeping them safe in the community. And clearly, the FIDA plans are not being compensated accordingly.
I just want to reiterate, just with the commentary section, this is Madeline Royal speaking again. Transportation was an item that came up or an opportunity for commentary there. So please do go back to the BML, any suggestions that you have, and a lot of the commentary that was presented, this was based on the feedback that we received from you and suggestions that you had as far as what we can do to change or what this program should look like. So
But from demonstration year one, we
Right.
saw, like, I don't want to say abuse, but now that there's more awareness of the rich benefits within the FIDA product, we're seeing higher utilization. I don't know if it's a direct effect of the DOH marketing campaign, but there's definitely an awareness. I mean, obviously, when we have a new member and existing members, we educate them on the full package of the benefits.
And these are some of the details that we really would like to see in the comments. You know, we have some of our regulars who comment and give us, you know, some of their suggestions. Please do include these types of details so we can take that into consideration as we're moving forward.
I just wanted to address one.
Someone new in the back who hasn't commented yet?
Yeah,
Go ahead.
I just wanted to say, I see this as a value-based payment discussion too. I mean, you know, you're talking about not being compensated adequately, but the savings are supposed to come down the line. So that just points out why the insurance model does not work from doing what we want to do. I mean, let's face it, you know, you're looking at a premium year, or you're looking at somebody who can leave your plan before a premium year is even up, and your savings are down the line. And so all of you are like, I mean, the other thing that you can do is try to keep your person and keep them with your plan and keep them healthy and alive with your plan. But, yeah, it takes a longer-term perspective, and this model just doesn't work.
Can I ask someone to just sort of clarify what I'm hearing here? I mean, one thing is we're saying that the care management and how that's paid for in the rate is really largely just a function of what the ratio is. But I'm hearing, you know, obviously we have other components to it, added benefit or requirements of the contract, such as the IDP or touches and things like that, that can obviously complicate that factor. And we're saying also that the care management, you know, isn't even just meeting those ratios isn't necessarily adequate with how many hours are in the day for the care managers to really give the highest quality, better care management that it might be looking for. But where I think I do struggle, and I'm interested in hearing insight, is, you know, those ratios are obviously they're limits. They're must have at least this many care managers. They're not necessarily saying you can't opt to go above. So are we saying that we think in the framework of an integrated product that plans can't stand to garner efficiencies through greater investments in care management above and beyond what the requirements are, and, you know, recoup those efficiencies down the line? Do we think that that can only drive higher quality, but not quality that would turn into efficiencies or savings?
What type of efficiency? You know, a lot of times I have these discussions with others in the Department of Health that, you know, use the words driving efficiencies. But tell us what that means. What type of
hospital potentially avoidable complications in hospital admissions?
Is there a study on the percentage on the return that's supposed to be? Because it's all theory, and we're at risk for that.
I mean, I'm not a clinical person. I'm asking the question of you folks who are in the industry. I mean, so you're saying that we don't feel that there is a benefit in terms of efficiency and cost.
That's what you're talking about is VBP.
Yes.
It's VBP.
Yes.
But
VBP is this that requires a relationship with the provider downstream in a contractual relationship.
But in the long run, what you're talking about in way of layering savings is really what driving towards VBP and the different layers of VBP, because you have to have the relationship with the provider. It's not just going to be not just going to happen because a care manager is constantly providing the care management component to reducing the hospitalization.
Agreed.
So, because no matter what, if a care manager is trying to do their job, if somebody is not in the home with the individual, and the individual, something's wrong with them, and they're scared or whatever, they're going to call 911, whether the care manager tries to stop or tries not to stop, but tries to coordinate care. You know, call a physician, call the whatever they're going to do, they're still going to call 911 and have that hospitalization. You need the buy-in of the licensed agency with the aid training, and you need the physician or the PCP to be able to work together all as a group. It's not just the care management component that you're going to be able to say. You have care management, and you're going to be able to drive down hospitalization. It just doesn't work that way.
Yeah, I mean, it's care management and administrative costs and technology infrastructure and establishing those lines of communications. And
Right, but again, let's get back to real numbers, because I'm finance person, I'm not a clinician either. But if you have a ratio, and I'm not saying that the ratio out there is 1 to 150 on the average versus 1 to 175, just to make the numbers easy. If you have 50 care managers in a plan, and they're at 1 to 150, you need to double that and have 100 care managers if you're going to go to 1 to 75. And each care manager, downstate New York, is going to cost close to, if not more than $100,000 with loaded benefits. It's going to be more than that. You're talking about a significant increase of cost. How many hospitalizations do you have to reduce to offset that cost? It's not going to happen. I'm just playing numbers-wise. And I'm not saying that it can't be done. You don't drive down possibly some costs. But when you just say efficiencies, you got to play numbers-wise. It's going to cost more.
At the current compensation level, it's not worth it economically to do that.
It's good to see finance and program at the same table. I mean, I think we've been saying that at meetings before, because you do really have to do a real analysis of the cost proposals that the program side makes, and provide the funding if you want it to happen. That's the reality. And given all the statements that I've heard from the department about budget shortfalls and MLTC being over the Medicaid global cap, I mean, you really have to think of the big picture and whether or not what's being proposed is realistic within that global cap, because that's what the governor's Department of Finance is concerned about.
Also, we don't have a care manager here. Like, if we are going to have a conversation also about, like, the tools that care managers need or et cetera, I think that would be something that's beneficial, would be to engage with the care manager. And that's also what we're talking about with IDT, is exactly what you were speaking to, is, that they're the collaborators in this system. And then also, having worked with consumers, the care manager is their entry into the plan. Like, that's really one of the only people that they're communicating with regularly. So if we're talking about how a plan is successful, we need to just further address what it's like to be a care manager. And I think we need to hear directly from care managers alongside everyone else in the room here that has a higher level finance, proposal, risk factor adjustment, jargon. We need to have the actual members, employees of the plan that, do the work. And then I think that we can have a better, more comprehensive conversation around, what's realistic, not only what's realistic. Because also another thing is looking at the actual contract, what we're talking about. A care manager has so many responsibilities. Even if MLTC, which is partially capitated, it says in the contract that they need to take care of several different factors that the plan isn't even paid to necessarily do. It says that in the contract. So I think that we also need to look at the contract language and go back if we're going to have a more holistic conversation around care management and what it means to be a person in a plan that's working with a care manager.
And I can tell you that would be one of my care manager's biggest complaints, is trying to track down things that a plan is not necessarily responsible for, but that portion of the coordinated care, trying to talk to a doctor's office, has no stake in the game with us, per se.
You mean, but not responsible for, you mean not making the actual payment?
We're not making the actual payment, so why would they give us anything, to be honest? And my care managers really struggle with that.
Right, and I mean, would you see that as an argument for more integrated, more streamlined benefit design, or do you think that that's severable?
Yeah, no, I mean, I think isn't that sort of the eventual goal of all of this, is more of integrated care?
You think, yeah?
I think this is Matt from Village Care. I mean, I think you've heard even in prior sessions about plans saying we'd actually prefer to have more control over those elements. I mean, things like mental health services and outpatient treatment. I mean, we're really going to be able to manage the whole individual. We really need to be able to know what's going on in the individual's entire life, and not just what we have contracted control over.
Mm-hmm. And if you do that, I mean, again, it's a question: is there opportunities to drive efficiencies under that framework?
That goes back into driving efficiencies. So many years ago, I did a study where we looked at disease management and impact on the overall health. So yes, it improved people's health. We reduced hospitalizations, but the cost, administrative cost, plus the pharmacy cost to avoid hospitalizations was more than the reduction in hospitalization. So it was great to make people healthier, but didn't reduce the bottom line. So it's, once again, it's expectations here. So,
I also just want to comment also from the care management perspective, being a clinician, I'm very engaged with the care managers. There are a lot of social issues that the care manager has no control over, and they're actually waiting on an external entity to help the member. I know, you know, by reviewing success stories, you can see like the collaboration and the amount of time that the nurses spend, because the social work is a lot of social issues. And I mean, you can't just say, you know, the ratio is 1 to 100, because each participant has, they're unique. Yeah. And I have to tell you, within this population, in addition to, you know, them being frail, they have a lot of social issues.
I just actually wanted to address one other thing that you had said about the medical components rolling forward. That's true, but again, talking about layering in additional benefits, and I know you talked about transportation. If you layer CSBO in, you don't have the experience that needs to be put in there as well.
Yeah, well, that is definitely a challenge for rate setting, and, you know, we're aware of that, and we're committing to getting that as accurate as we can. I mean, we're obviously working through that, but we appreciate that's the difficulty in that.
Can I just say one more thing about care management?
Okay, I just want to, last one though, because I feel like I might have taken us down a rabbit hole, and
I mean, I've worked, you know, I'm a government affairs representative, but I sit near the care managers who are always speaking to our members and working closely with them. But the other obligation that they have is significant documentation. So it's not just the relationship with the member, which, you know, is critical, but it's their documentation responsibilities. And that's an important component, which in your calculations, I don't know, you know, if you're thinking of that, but I think I would really take that into consideration, all of that as you calculate the rate.
I'm curious, would you consider the documentation like burdensome to a point where it is not helpful, and it's driving costs but not necessarily benefit? Or are you just more concerned to make sure that we're considering that in our pricing?
I think we need to consider it in the rate setting process and in the proposals on the program side for ratios and for doubling the monthly contact with members. Realize that the care managers have other responsibilities as well.
Understood. Thank you. All right, so I'm going to move on to the next issue here, which we were talking about risk adjustment. And I think we were sort of touching on this before, where we have done an integration on the Medicaid long-term care product, where we have sort of brought together all of the common benefits, basically what is the MLTC partial cap benefits, the long-term care service and supports, and under our current models, that's sort of what we're risk adjusting on. That's for MAP and FIDA. That doesn't leave room currently for any sort of adjustment for any of the additional Medicaid, or at least under our present model, we don't have any sort of adjustments for the additional Medicaid services, whether they're, you know, additional acute care, pharmacy, Part D RAP, or what else we do, behavioral and substance abuse. And I'm interested in, you know, thoughts on, or I guess another issue would also be in, you know, our rate is really, our risk adjustment is really based solely on the community portion of the rate. We are not doing a specific nursing home adjustment. We're using a uniform nursing home rate in our population. So, I mean, first with the question to sort of the acute and additional benefits, you know, I mean, is that something that people see as something that, you know, our rates aren't adequately compensating or are not fully reflecting those differences in that, or is that more of an issue on for the acute care on the Medicare side, and it's not that relevant on the Medicaid side because it's a lot of, I don't know, co-pays and stuff like that. I'm not really sure how people feel about that. And then also on the nursing home issue and risk adjustment there.
So I think at least our experience on the additional benefits piece, just the additional benefits piece, I haven't seen a need for risk adjustment because it's small enough, and as you said, that in the dual case, a lot of it is handled on the Medicare side. If you're a Medicaid only, it might be a little bit of a different story. But if you just talk about that one component, I don't know necessarily, maybe others might disagree, but it's not going to make or break a program whether you risk adjust that or not.
Sure.
if you're talking about a PMPM that's, in total $100, $200, whatever the number is, in a little higher, a little lower, you risk adjust it because one might be at 1.10 and one plan might be on the lower side at 0.9. It's not so significant that you necessarily need to take the time to adjust that small component to it. The nursing home side is a very different story, and I was going to get to how are you handling nursing homes.
I thought you were talking about nursing homes for a
No,
second. Okay.
No, I'm talking about the additional benefits, pharmacy, certain additional benefit components that are, you listed them out, not the nursing home.
Okay. Yeah.
It's a very, very small component.
Yeah, it's behavioral and substance abuse, some Part D pharmacy wrap, and additional acuity.
Yeah.
I mean, it's a lot of co-pays and co-insurance and.
We don't have claims experience with that population personally, so I wouldn't even know whether it needs to be adjusted or not.
It's not material, at least for our plan, we have experience with it. On the nursing home side, that's a separate conversation in itself, because as you know, there have been plans that have been pushing, and I think, it's been the general push to have a separate rate cell for the nursing home component.
Right.
Because the nursing home population and the cost that swing between one nursing home and another nursing home, if we're going to be required to pay benchmark rates, is so much in there.
So, I mean, currently what we're doing in our integrated and our partial products is we're doing our surveys, right? And we're going back and we're adjusting. So mathematically, that is sort of currently the equivalent of paying, the timing is obviously different, but mathematically it's the equivalent of paying separate rates, right? Another point that you're bringing up has to do with, benchmark rates, and I understand there are all sorts of financing policies, and they're not really limited to necessarily integrated care, but just in terms of acuity, I mean, do you see it's really more about the varying nursing homes as opposed to any sort of acuity?
Well, when you say acuity of a nursing home member, unless you're just talking about specifically the care management component, the nursing home's taking care of the patient, and they're paying all the costs. That's on the nursing home side of reimbursement of DOH that really has to deal with that piece of it. We're not involved with it. We're required to pay whatever the benchmark rate is. We don't pay additional whether you have a higher acuity member or a lower acuity member in a nursing home.
Unless vent.
What?
Unless you include vent in there.
I'm not talking specialties. I'm just talking about the 90+% of the long-term population in a nursing home. That risk adjustment piece, as you said, is sort of being taken care of in a retroactive way. It's sort of a guess, and then you retroactively change it. Then you have the pools to try to offset high-costing homes. I think everybody would be a heck of a lot more comfortable with a separate rate cell because then you don't really have to deal with it. But risk adjustment-wise, doesn't make it. We have to pay what we have to pay. We have to pay the benchmark rate.
Can I just pose one other thing? There's always some plans say that their rate is too low, that there's some gaps in the risk score process. If we're doing integrated,
are you talking about for the long-term care?
Long-term care,
yeah.
For the community. But if we're doing an integrated plan, essentially the medical data is being made available. Would it make sense for the state to do a study of integrating the risk score from CMS and see how that would impact the ultimate cost of the Medicaid side as well? Whether there's any difference. Good people who generally have PHF or have things, or is there certain components of risk score diagnoses that actually increase or decrease the overall risk score? Just the idea of floating out there.
Using acute care data, something
to supplement
the UAS in terms of risk. Yeah, I mean, I don't know. That's a
theory.
Theory.
Can I just jump in there? My question is for Elder Plan. So you got into the conversation about a lot of the plans pushing for separate rate cell and the fact that you guys had to pay a benchmark rate and whatever was in that rate wasn't necessarily to your concern. But can you just go a little bit more into detail from the plan's perspective on how a separate rate cell would address the issues that you have and how that issue, and do you think that issue would be addressed simply from just tweaking or risk adjustment, an existing risk adjustment?
So let me just first say that Elder Plan is part of a larger system that has nursing homes within the system, so I'm not against paying the benchmark rate. That's not what I was saying at all. What I'm saying is that plans, that the difference in payment, at least downstate New York, I don't know the rates upstate, but I'm sure they vary tremendously also, can shift probably more than $100 on a daily basis. I'm not going to. No. You don't. You basically, your low is going to be around 200 to 220, and your highs are going to be 380, 390. So you can have a swing of more than $100, $150, whatever the number is, on a daily basis. So if a plan, now DOH, and I've worked personally directly with Dan on ours specifically, because we had a massive nursing home network, and we were having significant populations move into our plan on the nursing home, and we had to pay that. Now, originally, I'm just talking our experience, we had a low number. It was readjusted later on, and we received back within a material dollar amount or an immaterial dollar amount what we expended, and that's what the whole purpose of it was. But if you had a separate rate cell that was accurately set and a plan could bill on a monthly basis that rate cell, I wouldn't have to wait for that adjustment. What? But it's significant cash flow time. Significant.
Which is especially true now where we're transitioning the population in.
Right.
Right. Theoretically, we would achieve more of a steady state as we go forward.
Correct. But that's going to take a while.
But how does that reflect the variance?
Wait.
Yeah,
Let me just.
I mean, the surveys address the number of members that are actually in the survey. It doesn't address the actual cost of that member.
I understand that. That's what pool mitigation is for. And now you can argue whether pool mitigation methodology is correct or not, and maybe that can be tweaked. But that's what the pool mitigation is for. But I'm just trying to address the specific question as to whether you risk adjust it or not. It's not about risk adjusting. Risk adjusting is the individual healthier, or is the individual sicker? Do they have more needs and we're expending more costs, or are we not? And that's really the nursing home that is paying for those costs. On the Medicaid side, on the Medicare side, if they go to the hospital, it's, whatever their fee for service, or if it's within a dual product or an ISNET program or something like that. On the Medicaid side specifically, it's the nursing home's cost that they're paying for those needs. We're paying whatever we're required to pay through the benchmark rate. And so you probably have to talk to the nursing homes on that side. It's not us being risk adjusted. It would be the nursing homes that they need. My side is paying what I'm required to pay, whether the patient is 100% healthy or whether the patient is really really have a lot of needs. So I don't think risk adjustment is really going to address that. Unless risk adjustment just adjusts for high-costing homes versus low-costing homes. I don't know how you do that.
It's a little different than a risk adjustment.
Theoretically, from my perspective, take the cost of the day per nursing home, put the add-on of secure management and admin expenses. That's what we should get paid. Why put us at risk for whether our members end up in more expensive, less expensive? A 5% withhold and distributing that out is not going to help either situation.
But I think we're getting a little off the integrated topic. So why don't we?
But we have 60 minutes left. We have we can do 20 more minutes of the last 3 topics. I'm not sure how much further we want to go on to the rate side, Jack. If you want to talk about the last 2 bullets.
Yeah, I mean, I think one thing that's just important to keep in mind too is where we look ahead for well duals and expansion into the rest of the state. Does the idea of incorporating well duals make sense with any of the potential models that we're considering, be it D-SNPs or a more FIDA-like model or an MA product, and what makes sense in different parts of the state? I'm not sure if anybody has any perspectives on those.
I think all I would ask is that if you start to roll out, like let's say you take something like a FIDA, roll it out across the state, that there is a sort of streamlined process for plans to either move into the that product, or, you know, that the application process is smooth or easier. That's it. I mean, because if you know you want to start a FIDA project in Western New York, it's probably better to use what base is already there in places that already have some network, or at least half of the network in place.
And the bullet or the item on plan qualifications, we'll get into that a little bit the next 60 minutes. What we're looking for, possibly, and ask the plans what type of experience do you think is necessary for a plan to either be accepted into the future integrated plan.
Just to address question number 3, if you're going to include well rules, I would imagine you'd have to have a separate rate cell for them and deal with that within the contract, because the whole, you know, having a paid claim for CBMC service versus not, and what only can come back and recoup and all that, you got to deal with that with a separate rate cell, because those well rules, you're not going to have that. So, and that can't be all layered into one. I would strongly push for separate reimbursement streams on that.
On the last question, if you're interested in going to the whole state, the question is, obviously you mentioned before the network, but also some of the other mandates that the state comes out with will impact how rapidly you can build that network. You have, if we're telling people we have the network providers along with the DBP structure, well, that's going to take that much longer to build the network.
You're saying pushing forward on VVP at the same time you're pushing forward with integration of state.
VPA was an example, but it's really anything. It's a matter of what's their priorities. If the priorities to build the network, then simplification is key. The more pieces you bring into play, then that's going to impact the success. You also have things, the demographic differences, you know, it's where just what happens upstate, the different experiences they have versus mid-state and then downstate. There's all these components are going to have different reactions to the same product being offered throughout the markets. Simplification will make it clear, but you're not going to get the bang that you're looking to get necessarily.
I mean, when you look on Medicare, the Medicare reimbursement, the base rate is adjusted very, you know, by county. So if you look, there are such drastic variations between each county on the Medicare side that I think, you know, upstate you'd have to really maybe try to align with how Medicare reimburses to make sure that there's that true alignment.
All right, thanks. And then I know we have 2 items on slide 7 that's related to this too, why Jack is here.
Yeah, I think actually the first issue we've actually touched on quite a bit throughout some of our other topics that we're talking about. You know, we're integrating value-based payments and plan quality into our structure. And then, you know, finally, I'm not sure if anybody had any thoughts on reserves, financing requirements for plans under an integrated framework and how that may differentiate from, you know, more traditional models, or there are differences between the programs that people find relevant. Well, and in the interest of time, I think we can move ahead to some of the other sections.
Okay. Thank you, Jack. Thank you, Jessica, on the line. And let's move on to the next topic on your agenda, which is the outreach, education, engagement of the participants and the providers. And Renee Labritz will go with that.
I think I have a less stressful topic. So again, we're looking for some feedback with some of the questions that we bulleted. Like with any new program, you can't really predict what will need to be changed until there's trends and data that shows some of the adjustments that need to be made. So what steps should the state and CMS take to outreach to educate eligible individuals prior to the launch of the program and after?
I mean, I would say that everything on this list of provider training that is standardized across every plan should be done by the state or CMS. It really doesn't make sense. I mean, all the plans are contracting with the same providers, right? So every time you require a plan to do training, then that provider is going to have to do multiple sessions of training, and anything that takes the provider away from being in the room with patients and getting paid is going to discourage providers from participating in the program. So, I mean, I see things in here, right, that the participant ombudsman, that doesn't need to be done by each plan. It's the same entity that's doing the same thing for every plan. ADA training, same set of standards. There's quite a few things. I mean, obviously, each plan will have some different care management policies and procedures, which they might have to be responsible for training their provider on their own, but anything that's standardized across all plans should be done by a single entity.
The question was about outreach to eligible people for the program. I think what Renee
Okay, I mean, I think the question, okay, I thought the question included
not
providers.
you directly, but does anyone else have thoughts on, I mean, there are a lot of things that the state did more recently with the ad campaign, but didn't do it first, and, you know, I mean, what are your thoughts on?
Well, I think you know what all the plans' thoughts were on the latest or most recent efforts around restrictions on advertising and where we thought the challenge was, whether it was the plans, it was with the providers. I don't know if we need to rehash those issues. We would hope that those conversations were learned by the state and they won't be repeated. You know, I don't feel like we need to like rehash what is sort of recent old history around this. You know what the plans felt like, that you were targeting the wrong audience, that the growth wasn't coming from us, it was coming from other places, and I don't know if it's helpful to rehash that conversation here.
I mean, is there a provider organization or entity that we could solicit feedback at the provider level? I mean, I feel it's very important with, you know, regard to provider engagement. They will actually, they're the secret sauce. If they don't support it, it will fail. And I think, I mean, the experience that we had in Choice is that a lot of the providers had a bad experience with the rollout, and they told our participants to disassemble, despite our educational efforts and the richer benefits in FIDA. So
very specifically the PCPs.
Yeah, I mean, it's
very
just so
specifically,
burdensome.
the physicians have to buy in. If the physicians buy in on day one, you're going to have a program that works. If the physicians don't buy in, the plan change. The product has. They're that crucial.
Yeah, and I think practical application training is very important, not just high level. So just to speak for an example, there's been lots of trainings on value-based payment, but there hasn't been any sort of like, well, this is how you actually go about doing it. Yesterday I spoke at the NISHVA conference, so with nursing homes, specifically on value-based payment and how to enter into contracts. We have like 6 weeks to get this done, and they were just looking at me like I don't know how to do this. Where do I get? They're asking me where they get their own PAH data. Like it was. So I get it. There's a lot of training that went into it, but no one who actually sometimes you need sort of with things that are brand new like this, like a little bit more of like these are the details, these are the specifics. This is who you're going to reach out to. This is who you can go to for help with. You know, if you have contracting questions or yeah. And so getting the buy-in is very important, and talking about those. Like the nitty-gritty stuff, not just the overall big picture.
Yeah, I mean, one of the things we didn't talk about here at all today is VBP and the financial parameters around VBP from plans, which is, I would assume, a big component to what we're going to have to do in the future of integrated care. And I know what's in the roadmap. I know what's in the contract between the state and CMS. But outside of saying you have to do it, the state, we need plans, have been telling over and over again to the state that providers who cannot effectuate change, so a PCP trying to convince a PCP to take a risk on members' hours, it's just not going to happen. They're not going to do it because the risk on their side, they're not going to take downside risk. They'll take upside risk, but that's only VBP level 1. To get to VBP level 2, you need upside, downside risk. And the providers, whether you're on the PCP side and you're trying to get them to take responsibility for total cost of care, you know, shared risk, the day you pull back from that provider is the day that that relationship is over. And the same thing on the license agency side. And so we didn't talk about it here, and it's probably not the right, we probably need to talk about that as DBP, but if this needs to have DBP level 2 and 3 layered in it, plans need to understand, and providers, training, education needs to be out there to say, this is the way to get to it. Because we can't force a provider into a relationship. And one of the conversations that I heard, well, I actually had a conversation, which is plans are going to be penalized if they, in the future, if they don't have DBP level 2 and 3. You can penalize us all you want. I can't force a provider to sign a downside risk contract. And if you're going to penalize us to the point that we're not going to be able to make it, then you're just collapsing the program right away. Because plans cannot force providers to do something.
So David, or other folks, when you talk about some of the shortcomings on the FIDA side with the early outreach with the providers, what have plans done to make, or what are your thoughts on how do you create a more robust provider engagement process? And, I guess if we're looking forward, and we're talking about education and what constructs providers, can be innovative within, like maybe if it's not directly with the plans within an IPA or an ACO type of arrangement, what are some of the other thoughts about how an education and outreach would look like more ideally, knowing what we know now and having experienced some of the...
Honestly, I think DOH should sit down with the providers and say, give us feedback. I want to hear from you providers, what will it take for this to work? Because giving them training or your thoughts on it or what, they have their own thoughts on it. And if it doesn't work for them, I'm telling you, it's going to end up coming down to money. But forgetting that piece of it, if you bring the provider community and PCP, IPAs, ACO, if you talk to them and you say, what is it going to take from us to get you to buy into this program way before the program starts? That, if there are reasonable requests or things that can actually happen, and then you bring the plans into it and really have an engagement of a conversation between the provider community, the plans, and the department, and CMS for that matter, that's the way to get this done.
And building on that, though, you need to have, you mentioned the IPAs, the ACOs, each of those are individually grouped, and then you have the small docs, the PCPs, because bottom line, most people don't go to an ACO or IPA. Most people have their doc that they had all these years. So if we carve out that population of providers, you're going to have a large population that's not going to enroll in the plan. So you have the big groups there, but you also have a strong representation of the small doctors, and you're going to have a challenge doing that, getting them to the table, because most of them are 1 or 2 man shops. But I think that is probably the most critical component, is getting the individual PCPs to the table. And I'm going to stress once again, all these things are going to cost money. So where's that money going to be coming from?
I guess one of the questions, Judy, I just have one quick comment. My question to you, what are the plans doing, though, to engage? And I hear that, and it's good, we can take that back, Dave. I think that's good to think about how we do engage the providers in several different forms, but I think we can continue to, in light of the future of integrated care model, to think about, the best place for a roundtable discussion to have that. But I'd like to hear more about what some of the plans, again, have done to date, firsthand from the folks who are here around in the webinar to engage the providers, right? So, on one hand, we can take responsibility, but what are you guys doing?
I'll give you 2 different examples, and it's only our experience. I'll give you one on the Medicare side and one on the Medicaid side.
That would be helpful.
So we have risk-sharing relationships with a couple of large IPA, on Medicare, this is, Medicare side, are not we do have FIDA as part of it. FIDA, MAP, our DSNP, our Medicare contract, we have an outside risk-sharing relationship with it's upside downside actually, risk-sharing relationship with an IPA, a large IPA, where we have a significant number of members throughout all of our products, and we, on a monthly basis, sit down with them and talk to them about medical management initiatives and different things that we do to try, we have to provide them information, and they then review the information, see why you're having multiple hospitalizations on members, what can they do to stop them, because they're at risk, but they're at risk for the Medicare component. If I layer that in with a MAP product or a FIDA product where I set for them a budget that they have to achieve better than that, they have an upside payment lower than that, they have a worse medical loss ratio, they have a downside risk sharing relationship. If I layer into that the hours of the member, and the members have high utilization, everything and anything that they work on the Medicaid side, on the Medicare side, and reducing hospitalizations is going to be out the window, because the member has high hours, and the capitation from Medicaid is not high enough to offset the cost of the high hours. And even if, and these members are the ones who are going to have high hospitalizations, you can bring them down, but the revenue stream is a third, is a quarter of what it is on the Medicaid side. So if they reduce hospitalization and you're reducing your MLR on the Medicare side, but your revenue stream is, I don't know, $1,500 PMPM, $1,800 PMPM, but you have high hours that are costing you $8,000, $9,000 for the membership, and your capitation is $5,000, $4,500, everything that they do on the Medicare side is out the window, and they're going to owe us money back for the member having high hours. It's not going to happen. They're not going to do it. And so that's where the challenge comes. So on the Medicare side, it works, and we do it, and we've actually had some very successful relationships that way. On the Medicaid side, we've had sit-downs, and we're looking to try, we're getting to a place with a specific licensed agency, but that licensed agency also has to it a separate wing of NPs that what we would like to do is to try to pilot a total cost of care relationship with them, where they have X amount of members with us in our FIDA and our MAP product, and they take total cost of care, which includes the Medicaid hours, and it includes the Medicare component. And if their training of their aides and the training of their, and within their Medicaid side, the licensed agency side, can identify early signs of a UTI or of sepsis or, you know, of things early on, and they can then send in an NP to go and avoid hospitalization, and they take the total cost of care into play, they'd be willing to, if they reduce, you know, we'll set metrics, they reduce their admits per thousand, they reduce their you know, hospital PMPM, whatever the metrics are, if they're willing to take the responsibility of the total cost of care, that would be a model that would work. But most licensed agencies don't have that other wing to it. Two examples.
That's helpful. I mean, in light of, not to get sidetracked, of, you know, the roadmap and VBP, and, you know, we did have a boot camp yesterday out in Long Island, in light of the fact that by 12/31, plans have to have in place contracts with CHAs, LHIPs, and SNFs. I mean, just hearing from others, you know, others, I would hope, engage in those conversations, or I don't want to get too detailed in this meeting about that, but I think it's a recognition of the fact that, you know, those conversations should be going on anyway. So I don't know if there are other folks that have comments.
There is a comment from the webinar. It's from Deanna Stevenson, the Director of Managed Programs with NISHPA. She said, plans have already started sending amendments for VBP Level 1 to SNFs. I am working and have reached out to the DOH team, and we are going to do more education for our providers, but I believe the amendments sent did not and do not allow the provider to have that conversation. It was a take it or leave it amendment. So that was just her comment.
Okay. Thank you, Deanna. I appreciate it.
Just addressing your comments that what plans are doing, I think the challenge what you're having in the population over here, I mean, I don't think any of us is Unite. I don't think United has to say anybody like that, but most of us have only a few members by the doctor. We have the same issue regarding the VBP. For us to have a conversation with the doctor that only has one or two members, we don't have the resources for that. So the ask is not reasonable. The only place where it's possible is to have by a broader IPA or by an ACO. then theoretically you have that possibility. But then you're precluding the entire population that doesn't belong to an ACO, that doesn't belong to an IPA, which is a large part of the population that you're focusing on. So what is the goal here? The goal is to get part of the population that belongs to the ACOs, or is the population to target all of New York State and their needs? So if you're asking, are we going to have a conversation with a doctor that has 1 or 2 members on plan? You can't.
Let's just be clear on what you had just said, which is due in 6 weeks from now, and to address the answer. The requirement for 1231.17 is upside risk only. So the provider has no downside risk. Much easier conversation to have with them than when they're $1.
And I know you mentioned, level 2 and level 3. So yeah, we don't want to conflate the two.
Right. And with what Deanna is saying, plans are just scurrying to get these things out because we have this requirement.
Okay. I just want to be clear. I mean, just because there are 2 disparate conversations, but just because there should be an engagement, obviously, because of meeting level 1 targets by that date, just I didn't hear a lot of discourse about just any engagement, so that's what I was curious.
I want to add to that, though, not to go down a VBAP path, but it's very difficult to have conversations with incomplete data. So we would tell providers along the way, like the nursing home providers, that this is coming, be prepared for it, but we can't tell you a dollar amount attached to it. We can't give you the exact measurement. There's a lot of issues with what members during that specific time frame actually qualified, and if skilled nursing facilities did not have enough members with any one plan, they couldn't use an individual PAH level, which means they have to have aggregated data. I can say that even for myself, as of this date, we do not have that data. So how can I send this out without having that yet? So it's just, yeah, we're having a conversation, but it's very difficult for me to keep calling and being like, it's coming, but I can't do anything yet.
The time restrictions, too. I mean, we have to get these guys, Erin K told us we have to get these contracts approved by DOH before we can even send them out. So there's really not a lot of time for us to get this thing done.
And we haven't been shared the money. We've heard theory about the money. We haven't been shared the money. So we're supposed to put in a contract some sort of reimbursement and have the conversation about the reimbursement. And we've been told since the beginning it's coming, but we're being mandated to get these things out. But the state has not been participating in the things in their share of the burden here.
We can take that back, and at the risk of sounding like a broken record, I defer to DFRS, but there's a deck, and there are there's a presentation to share on the funding portion of that. So that's a whole other conversation. I don't want to get involved. Sidetrack. Okay. Well, does anyone else have anything to add before we move on this topic?
Just on this outreach, I think a lot of people raised their eyebrows with the advertising that did go out. Was basically that it gave members expectations that they were going to get full live-in and plus all-week social care.
Regarding the advertising.
By the advertising that happened. So the advertising was that we were able to give somebody a full-time aide, and now we had to also give them social daycare on top of that. That was advertising. I forgot the exact wording. But
the radio ad?
The radio ad that was going out. And it just gives them, it was that we were able to have the person, and the person was able to get a full, an aide full-time in their thing. And now I have to address their social needs as well. So I was able to hook them up with going to a social daycare during the week.
Mm-hmm.
So just, you set the expectation, you gave the impression that you're good with the max benefit to anybody that's enrolling. And that's unfair to the member. It's unfair to the person assessing the needs and telling them, oh, you're not going to get that. It sounds like a little bit of a bait and switch that puts the plan in a very uncomfortable position for. So it's a matter of if any advertising should be a realistic expectation for the member while he's still promoting the needs or the benefit of the plan that's going out there.
All right, we can take that back. That's good feedback to have in terms of future planning for advertising and for the future integrated product. Yeah, Judy.
I just want to reiterate what some people said, that potential members or current enrollees in these products really rely on their PCP participant in advisory committee, anytime their physicians have a question about FIDA, we go out and we talk to them about it. But I think for the future, it's really to make it less burdensome for them to be engaged. Because I think initially with FIDA, they didn't know what it was, they didn't understand it, and if the potential member went to them about it, they didn't really have a clear concept of how it would impact them as a provider and what their requirements and expectations were. So I think primary care providers there's a shortage. They have a lot of members and patients besides the FIDA population to deal with. And we have to make it easy for them to participate in this and give them incentives. And that includes, they need to be paid for their time too. And that's really important.
Thank you for that comment. Anyone else? Yeah.
So at this point, do we want to go any further into the education? Do we want to move on to the next topic here?
Why don't we move on?
Okay.
So, my name is Alyssa Halford. I'm with the FIDA team. Here, what we're putting forward. Here, what we're putting forward is really a question to the group and looking for stakeholder feedback as to what factors the state should consider in deciding which plans to allow to participate in the future of integrated care and the next integrated care iteration. What we put together for you are some examples of criteria that other states use in evaluating which plans to allow to participate. And, they make other, in other states, the states require plans to essentially demonstrate their ability to provide the services, to monitor networks, to build networks, to implement in all the, various service areas. And there's more showing that's necessary, and then the proposals are evaluated. And so I guess we're looking for some feedback as to whether there are stakeholders who feel that we should be using, a process like this, where we're actually considering some more of the factors about the nature of the plans and their abilities to meet the needs. So, it's looking at these, which we sent out to you, and these come from many different states. But they look at things like their ability to use technology. They look at things like, their policies and procedures. And this is stuff that goes into the bidding process. So I guess we're looking, what
that seems awfully complicated as opposed to just saying that plans who currently have a similar product, be it FIDA or MAP, are the ones that are eligible, opposed to going, or paid, excuse me, correct, opposed to going through a whole separate process.
I was actually going to say, and it's probably going to be an unpopular comment, but plans who stayed in FIDA, have stayed in FIDA through 2018. Right now, there's, to my knowledge, absolutely no incentive to stay in for 2019 because the product's ending at the end of 2019. We have no idea whether these members are going to, where these members are going to go. So are they going to roll back into your MLTCP? Are they going to go into this product, if you can even have this product, and so on. And from a financial standpoint, at least I can speak to our plan, not like we're making a profit on FIDA. We've been in and we've lost a tremendous amount of money on FIDA over the years. And to me, I'm not saying that it has to be only the FIDA plans who stay in, but at a minimum requirement, I think it should be what's been said, which is you've got to have experience doing this. And whether you were a MAP, FIDA, both, PACE, a plan that has experience with running a dual integrated plan, I think is essential. And it also goes to, I think Jason's, wanting of there to be less amounts of plans out there and less amounts of, this shouldn't be an open season, anybody can get in, I don't think.
I mean, if you have those products, you have all the technology, I mean, you've demonstrated by having those products, you already meet all the other, the laundry list of questions you have. I mean, you can't have that product if you don't have the technology, if you don't have some of the other stuff you're asking for.
So, David, are you saying you shouldn't be able to exist as a standalone MLTC unless you have kind of an integrated product?
Tell me why you should.
Why shouldn't we? Well, I mean,
Well, I think the conversation would be different upstate, right? Because
I
we
mean,
don't have the opportunity.
we don't have the opportunity.
Yeah,
I'm not talking about, I'm talking about those in downstate.
Just down, okay.
Five boroughs, those who've been doing it over and over. If you don't seriously, if you don't have the opportunity to be in a FIDA, then you don't have the opportunity to be in a FIDA. Math is scarce up there, and there are only a few PACE programs.
Yeah.
But downstate, there is a tremendous amount of competition, and there's a tremendous amount of plans that all were in for FIDA. Oh, let me be in FIDA. Let me stick my toe in the water on FIDA. No, I don't like it. I'm pulling out. I don't think that those plans should be rewarded with being able to go in.
So I will not disagree with you at all. Just then, strictly speaking, for the rest of state, if you have an MLTC only plan, but you know the market very well, you know the differences there between, you know, downstate, I think you should absolutely be offered the opportunity, especially if you have staff who have experience in PACE programs and that, and why not? And
I think part of the reason we asked the question is that we did hear a lot of feedback for FIDA. Some of the plans that joined, you know, that began participating when the program first started were only MLTC, and some of them were only Medicare, and there was a big learning curve, you know, for those plans on the parts that they were, you know, not experienced in. So that's just part of the reason why we asked the question. I think it was a good conversation. It'd be interesting to hear from, you know, any people in the room who aren't, you know, with the plan.
Well, I would hope the state is not thinking about allowing new entrants into the market, like brand new entrants who have no experience, who've never run this kind of product.
And what do you mean by this kind of product? A Medicare, Medicaid combined,
Yeah.
and what if we run it in a different state? So, I mean, these are why we're asking questions. I think that the question, I don't think any, you know, this is just putting it out there. We're trying to get you to think about some of these factors.
I just,
like,
yeah. I mean, Matt's point is basically that all we're hearing about is we need to drive consolidation. There needs to be consolidation of plans. Opening it up is not kind of counter to that.
Right, and there should be some sort of reward for those that played nicely and stayed in.
No, I don't think we're necessarily, all I was saying back was when you said should MLTCs be in, I'm just saying that plans who stayed in this, as Megan just said, there's got to be something for us. There's got to be something, and we do have the experience because we've been in it. And I just feel very strongly that along with what's you're hearing, that not upstate, not in areas that didn't have the opportunity or only minimally had the opportunity, plans shouldn't be rewarded for not playing along with, not being a partner with the state and with CMS in these products.
I mean, Matt, thank you, David. And I think, Matt, we can get to that point, and that might be a future topic. I don't necessarily think we were on any level proposing that we have, you know, listed any sort of moratorium and have open season on new plans coming in. Yes, it is antithetical to the consolidation we're seeing in the market.
Are you thinking of plans from other states coming in? Because I know there's a large for-profit that's recently come into New York State. Are we thinking of allowing those entities?
You know, I don't know of any that have proposed that. You know, that's something, I guess, that we could talk about. I don't think that's the department's intent here in having a conversation, is to start looking at how we can bring, you know, interlopers, if you will, into New York State.
Not only that, New York State is unique, and you have to be here to understand what that means to be in the market in New York State.
I think we have seen some consolidation market, right, with some bigger national forces already, you know, so that will go on, but I don't think there is a concerted effort that we're saying in any way, shape, or form on the part of the department to push the forces in that direction here.
Yep. Our name's Darby Anderson. I'm with the licensed agency, also with a provider, home care provider from across the country. If you wanted a non-client perspective, I would agree with what the gentleman said, that having the experience in running a duals program is critical in its success. You can't, you know, just convert from, you know, an MLTC to a FIDA plan. So I just offer that support. I'd also, not relevant to this, I would offer that, you know, talking about the MLTC program is really not a very effective program, and therefore, what happens with that program and the providers in it, I don't know, but it's a function of the gentleman over here talks very directly about the integration of the long-term care and acute side, and the primary care physician really can take risk and responsibility
what the MLTCP is and the contract that we have, it is an effective program. You're talking about, is it an effective program in reducing hospitalizations, in being an integrated approach with the Medicare side, the acute side. And I don't think until more recently where there's been this push to try to, I mean, the quality measures, the whole piece of quality that layered into MLTCP, I think has started in 13 or 14. So MLTCP products have been around since 2001. Elder Plan has been running since 2001, 2002. I would say it's an ineffective product, but there hasn't been the approach until the last 3 or 4 years to really try to integrate that Medicare piece of it. And now there is that approach. And so I'll go again with saying that I think if you've had the opportunity and you've run a dual product, you understand really the relationships you have to have with the provider, with the PCP community, with the physician community, and how different and complicated that is as opposed to the just a licensed agency relationship for one of those. That's all.
And the department came out with a report a couple of years ago measuring the success of the MLTP program. So that's worth taking a look at, that report.
For our PACE person, I'm sorry, I don't remember your name.
Sherry.
Sherry. What about the idea of a partnership? PACE is upstate. And what about the idea of a partnership between MLTC and PACE, given the fact that PACE is also a provider?
So can you give me an example of what you're saying, though?
Well, I just thought of it 2 seconds
Yeah,
ago.
we actually we have very seriously explored that.
Okay.
So my background is in PACE. So, I mean, I really believe in that integrated model overall. So we have very seriously tried to either acquire or partner very seriously with a local PACE program and are trying to now do the same with another. It makes perfect sense for the two to have some sort of marriage together. It really does. So I think there's a lot of opportunity of something to explore there.
And one
so I
of the
think it's a good idea.
I mean, we've suggested is that upstate there should probably be some sort of like pilot projects, and maybe you can let plans pitch something like that so that they can get some experience before we transition. I mean, obviously, if you're targeting a 2020 date, then that's maybe impossible. But if the rollout for upstate were to be later, we could start now sort of developing some pilot programs that would give plans a little bit more financial resources to explore some of those things and see what would be practical going forward.
Okay, that's very helpful. I mean, what I'm hearing is that, you know, there's some exclusionary talk, but I think, I want everyone to be reassured that, you know, this model we're considering for the entire state. I think there's an appetite to figure out, and on the part of the department too, to understand how that fits in the bigger picture of future models, you know, future of MLTC, future of MAP-PACE. What does having one integrated model mean if that's the case? And I think that's part of a subject we can have later. And then how do you access, right? How do you get in? And I think I hear from David that there's concerns or ideas about, you know, some of the pitfalls, if you will, that we've had with so many plans, and, you know, trying to better understand who brings the best experience to dual integration. And for those upstate who have had, you know, how did you pair with models like PACE, which are tried and true and have been around and expect to continue to be around? So are there opportunities within that for, you know, areas that have had lesser experience with an integrated product? So.
And at a bare minimum, if a plan does stay around and fight us through and has, you know, a product that is the next product, we should just have some smooth transition there, because otherwise the members are just gonna, I don't know where they're gonna go.
We agree with that, David.
Okay,
It's be a rocket
it's also
transition.
a smooth process that we shouldn't have to have that whole, you know, we're moving from a fight of this new thing to simplify the application process. There shouldn't be the 2-year process that it takes for the math to go underway. It shouldn't be just everything. Let's learn what we can from FIDA, the benefits, the math, the benefits, to take from all these experiences. FIDA works better on the enrollment side by having an integrated enrollment. MAP, the benefits are more aligned with need and doesn't have as many. I think let's pull those pieces. Let's simplify everything, and even transitioning to this new plan, let's try to make it easier for the state, make it easier for the plan, easier for the provider.
I have a question for the state. I mean, what do you view as the role of Maximus in this whole conversation?
Enrollment. We're going to talk about that in enrollment.
That's next? Okay.
All right, great. Can I just ask one more question, and that is, do folks have any kind of idea of why math doesn't have greater penetration upstate? Is it just historical, or?
Doesn't have that great penetration downstate, also it's only 8,000 members, 9,000 members.
It's only a few hundred upstate.
But there aren't that many. How many maps are there upstate?
Yeah, I don't.
It's just, could be just circumstances.
There are not a lot, and there's definitely not, I don't know of any maps statewide. I don't think there is one.
No, there's not, and I think the
not.
counties upstate, there's like a handful of counties where there's actually a map operating.
You guys can probably speak more, because I don't have experience in math yet, but I think historically what I've heard is the disconnect on the enrollment portion.
Yeah, that's
or enrollment, that's been the biggest hurdle.
Enrollment on the 20th day, enrollment on the 31st day, that's a huge issue that has to be dealt with, but FIDA dealt with it. So, again, taking the best of both products.
Okay, let's move on to the last topic, which is enrollment, slide number 10. And I guess let's go to the last bullet. Well, the question that came up. There you go. Thank you. What do you think about the inclusion of an enrollment broker to handle the enrollment process? And we talked about how it's set up. MAP has their cutoff, and the FIDA does. But what did you want to mention about that?
You're talking about the role of Maximus?
Yeah.
I mean, I think we.
Is your preference not to use?
Well, there's definitely a barrier.
Right.
I mean, we struggle sometimes, and I don't know if other plans have the same, with our submissions and the delay, and we need to follow up, and you need to call, and, you get your reporting, and you have a lot of follow-up and reconciliation that you have to do.
And that's what product line are you discussing that for?
So we have our MLTC.
Right. I just want to let everyone know that's the viewpoint that you're talking about. Okay.
We have we have a FIDA and we have MAP.
Right.
And also on the MAP side, we struggle also because of the discrepancy between Medicaid and the Medicare disenrollment dates. You really need to make sure if you disenroll with one, you don't lose coverage with the other, that the member knows that if they're going to the pharmacy, it doesn't impact their pharmacy also. So it's really educating the member and being on top of your records, your files, your reconciliation. Everyone has to be all together making sure that this happens so it's, seamless for the member.
I'm sorry, I definitely have an appreciation for the role of Maximus plays, because when you compare FIDA to MAP, the process is so much more easier. And the member isn't, like, if they disenroll from MAP, like, if you don't coordinate those dates, they're, like, sitting in limbo.
Right.
And with FIDA, it's just effective. I mean, they just disenroll and they go back to whatever product they desire.
FIDA enrollment is much easier than MAP enrollment. And you asked, Patrick, why you didn't specifically ask about downstate, but I actually think MAP would grow a lot more if you had easier enrollment structure, the structure that you have like in FIDA. You'd have much more enrollment because it definitely is a barrier.
And is it time frames only, or is it the process? Because
It's the process
Maximus is
and the
able,
time frame.
okay, so Maximus is able to execute the Medicare and the Medicaid enrollment from there.
It's both, right. The Medicaid, the Medicare process on the MAP side is more lengthy, it's more detailed. It takes the application, it's much longer than on the FIDA side. I'm complimenting FIDA.
I don't hear people complaining about the MAP product.
No.
People complaining about MAP administration.
We're trying to make it better.
Right.
So, that might be a good basis for what we come out with, and maybe it's just redesigning MAP to get rid of these administrative burdens. Regarding your question on Maximus, and I'm on the finance, I can't speak for the enrollment side, but just looking at the numbers that I'm seeing from Maximus, like they're almost enrolling almost everybody. So all that's what I'm seeing mostly is what's happening is the longer time frame now to get members on board, because they have to go from the point that the member is interested, going through Maximus, scheduling that appointment, and they qualify, which they almost always do, then they have to go through each plan's process, in which case, many more members, the plans are not going to feel that they qualify. Then you have to get Maximus to deny, or else we are faced with OMIG. You know, there's a lot of additional hurdles that, at least from the finance side, that I'm seeing with Maximus. I can't speak for the enrollment team; they're not represented here, but that if we whatever we could simplify and even potentially reduce the state budget.
I will also tell you that if this contract, the new revised one, ever goes into place, Maximus is going to have to change all their rules, because there are the requirements of 10 calls in 90 days, you know, on disenrollment from a plan, and within the new contract, we're supposed to initiate disenrollment after, if there's no paid claim within 30 days of service, of whatever it is, of, services, and you can't, Maximus won't take the disenrollment. He won't take it. So you're going to be sitting there having to do care management, and what happens if on day 45, the member then starts getting services? I mean, there's such a disconnect that if this thing ever actually happens, Maximus is going to have to redo everything that they did.
Not to harp on that, but help me better understand this. You're saying if they haven't had a claim for a service, or they haven't had the actual service in 30 days, contact or Maximus, right? Disenroll the person, but you're saying it's not getting processed, or
no, the new contract.
If there's a change in rules in the new contract.
Oh, in the new contract,
right?
Gotcha.
On the new contract.
Gotcha.
Nothing that's going on right now.
Yep.
If that ever went.
Yes, understood. Okay.
And just bring it through. So the 30 days didn't have services. Now on the 31st day they start services. We got to enroll them. We're finding services again, and there's a gap in care because we have to disenroll them. It's just a lot of things just doesn't make sense.
We're going to have a big conversation on that contract at another time.
Can I ask, the PCP in math, as long as they're Medicare providers, are there a lot of network restrictions, or?
You mean by network restrictions? You mean by us allowing them in our network?
Yeah.
What do you mean by that?
Is it fairly open as long as the individual is Medicare provider?
Depends on what you want your provider, your provider network to be.
I'm just thinking in terms of the ease of enrollment.
For the physician or for the?
No, for the patient.
I mean, in either product, if they're part of our network, it's, ascertained upon enrollment. So
there's still a network requirement.
Yeah.
Yeah.
I mean,
If they don't
have
have a signed PCP, you can assign them a PCP if that's what they want.
And if there's 5 PCPs on a network, likely they're not going to enroll on their own.
Right.
Right. It's not a network.
I mean, we could allow continuous care if the provider is willing to join the network, but sometimes the provider just outright says, I'm not willing to join.
It's just that somewhere in the back of my head, I have the idea that it hasn't caught on upstate because people are very reticent to change doctors.
Downstate as well. They're very committed to their doctors.
You're saying upstate they have there's less access to a physician, so once you have one, you want to keep it. Whereas New York City, your doctor pushes you off, there's one down the block.
But on the other hand, exactly your point. That's the challenges that Dave was saying and other people were saying, that if you do anything without those providers on board, now we're talking about individual providers, then you're precluding a whole section of the population from joining this. So if you could focus on ACOs and IPAs, you're precluding a lot of population because they're not going to switch to the doctor. Okay, let me finish this off.
Well. All right, so let's just go up to the top, and then we've got just a few, and then we'll be finished for the afternoon. Do you think the new program should be voluntary or mandatory on the Medicaid side for eligible individuals?
And it's just also about a lock-in period. I mean, I know Medicaid doesn't allow a lock-in, but there have been some experiments with this in other states, I thought. I'm not an expert on that. So it's a conversation about just what I meant, but if it's mandatory, is there also a conversation around...
Mainstream has a lock-in.
Which one?
Mainstream have a lock-in.
Well, mainstream, yeah, but integrated product includes Medicare, so inherently there's Medicare rules in there. But I'm wondering if there's creative ways. I mean, we struggle with this. We want beneficiaries to have a choice, but we don't want them every 30 days bouncing around. And that goes to the whole thing around rates and saving money, and you can't save money on beneficiaries only with your, or maximize efficiencies if they're only in a plan for 3 months. And we obviously, from a plan perspective, we'd like to see some sort of lock-in period.
Right, and the context of the first bullet was just looking at the Medicaid side, because, you know, if you're going to have the Medicaid, it could be the Medicaid product, or, and then just looking at on the Medicare, you're right, that's not allowed.
It's not allowed, right.
You know, so we were just, you know, asking about, if you think if someone is coming to the state, and on if this program is just for, on the Medicaid side, you want to make it voluntary for them to come in, or is it mandatory, regardless of what program they select on the Medicare?
I see what you're saying.
Yeah,
I don't know how that works
Yeah, I
out.
have a clarifying question. So we know that mandatory enrollment with FIDA was not successful because everybody wanted to go back to MLCC.
It wasn't meant to.
Well,
it was passive versus, those are two different things.
Then that's what I think this question is getting at, or what my question is getting at. And I think we're kind of like splitting hairs with the nuances. Somebody was put into a plan, and then they decided they didn't want it because they had other options. So is this question suggesting that folks who could also enroll into MAP or PACE or another integrated product, what does that look like in like the grand scheme of things? I know that those integrated products are not, you know, if we're talking about the entire MLTC population, which is nearly 200,000 folks, and you're talking about MAP and PACE and the other integrated care, it's much smaller, but what would the relationship of this enrollment be to these other integrated products? Does that question make sense?
Yeah. Yeah. Well, I think you got to decide like if you're going to keep MAP and FIDA, or you're going to go to one integrated product. I mean, I think PACE is going to stay PACE.
That's my question. It's like I don't think that we just mentioned that we're not going to take away PACE, right? So I think yes.
Doesn't it have to be voluntary if you're not going to take away PACE?
Well, you could require that they enroll in an integrated product. In an integrated product, it doesn't have. It could be
and what happens if you have provided pushback like we had in FIDA?
And that's kind of what I'm talking about. I mean, we did something very similar with FIDA, but we had the fallback of a partially cascaded plan option. And with this, it's just, I think that's kind of where my brain went, is folks are going to want to know what their options are. Yeah.
So what I'd be obviously concerned about is you have a provider that doesn't want to join these products, and now I'm going to lose all my, they don't want to join our network per se. Let's say they're willing to join a network but not B network. Now I'm going to lose all my MLTC members only to the one that the provider joined. So by mandatory, you're putting all my membership at risk.
I think part of what the question is asking is, what if it were mandatory on the Medicaid side only? But people still, because we cannot make it mandatory on the Medicare side. So they would have freedom of choice, and then you would have a product that has a Medicare component, but your Medicaid piece of it would also be able to work with original Medicare if people wanted to. This is done in other states, so I know you're making faces.
No, I don't understand it. How's that different than MLTC right now?
Yeah, I'm wondering, like, I'm just telling you how it's an integrated product. If you're only having.
No, because you have both. I mean, essentially, it gives you the ability to hold on to someone when they decide that they want to change their Medicare line.
Yeah, but that's MLTC then, basically, right?
Well, no, because it includes a lot more services, a lot more
a
lot more requirements around coordinating care.
I can't even imagine the complexity from a plan perspective trying to administer something like that.
Yeah.
There goes simplicity.
No, not really. I just, you know, there are mechanisms right now, assuming DSNP, the CMS side stays the way it is, they have that ability right now, and the other pieces that aren't covered in the wraparound are fee for service, right? I mean, how else are they wrapped around? So from a plan's perspective, I don't think you're going to get anybody in the room to say, we can administer something like that simplistically. I know, again, we run the map, we run the site. I can't even imagine. As a matter of fact, because of the disenrollment date change, we have to have a workaround to try to deal with that 11-day gap between a member who loses their Medicare eligibility but still has the wraparound Medicaid piece for, whatever is it, 11 days, 10 days?
No, another month.
Sorry, yes, another month, and we have to continue to pay claims. And we've had to put something in place to sort of deal with that situation from a claims perspective, from an eligibility perspective. That's just layering in more complexity.
Can I just also say, from a care management perspective, it's very hard. We're trying to move forward in integrated care, and the care manager is like the gatekeeper. It's going to be very difficult to coordinate with Medicare, the Medicare plans, and so it's like we're back to square one. So I just think, from care coordination, it would be difficult to administer.
But I think what Alyssa's suggesting is that it would be a Medicare and Medicaid plan offered by the same individual, right? So, and I mean, there are other states that are doing this now, like New Jersey, Pennsylvania is moving that direction, Minnesota has a long-standing way to do this. And so it's, essentially having kind of limiting the entrance of the DSNP and the MLTC market so that you don't have plans that are just offering MLTC or just offering DSNP, but rather they are offering them together and then trying to do the alignment on the back end. And I definitely recognize the issues with math and,
How do you mandate someone on the Medicare side? But that's, maybe I'm reading what's going on in Minnesota, but if Medicare rules don't change and a person can stay in Medicare fee-for-service, how do you make one product? I just don't even know how that works. How you manage
It might be
that
helpful if you could come back to us with some more information, how this works in other states, and it might be easier for people to get their heads around.
And just to layer another question mark on this, do those states have PPP level? because I can't imagine having a provider relationship where you're at risk for both sides, because we're at risk for both sides, but then certain members drop off of the risk of the Medicare side and still require them to be a level VBP2 and 3. I can't even comprehend that because of the level of complexity of trying to run your.
I think we can continue to have this conversation. It's a good one to have. I just want to be mindful of time, that it's already 2 o'clock. We had a question in the back.
Yeah, and to piggyback off of the suggestion for how this looks in other states, from my perspective, and what Angela and I are talking about, is the way that plans are marketed in retirement marketing and enrollment. Angela, if you don't mind me repeating, was told you need to have MLTC. So it's these are your MLTC options, and that's how the enrollment works. With this question, in my mind, I'm trying to wrap my head around, how to talk to somebody that needs long-term care about their options and what exactly does it look like. So, now I'm having a better understanding of, you kind of fully integrate it. Yeah.
And also, when I was told if I didn't pick one, I was told one would be picked for me. So I only had the choice of 2 of them. So one wasn't very good. The third option wasn't very good. So I only had 2 options, which no one told me anything about them. So I had to go to a health advocate to find out the information. So.
And I think it's important that we talk about it from the plan perspective of how does this actually look, but then also incorporating, okay, and these are I would benefit from a clearer visual of what options would look like, and how the counseling would work. Yeah.
Yeah. So, thank you for that feedback. That's helpful, and we can think about the best way to kind of map this out, and maybe that's part of future meeting that we have. So, I think we have one more bullet point, Joe, and then.
I think we're
wrapping up.
Yeah, let's wrap up this section, which is closed. Okay, so what we'll do for the next steps, our next session is in New York City. It's in the same room that we had our first kickoff back on July 20th in New York City. We'll be sending out materials on that. As mentioned before, we are Looking through the notes from today, we'll be reviewing all the numbers, plus all the written comments that we would ask that you send in to us within 10 days. We'll send out a reminder for that. And we'll be meeting with TMS to discuss comments between this meeting and the next on December 8th. So we do not anticipate that we're making any or announcing policy decisions before the completion of all 4 steps.
Please submit any of your thoughts before November 27th, which is not that far away, so we have time to consider any thoughts before the next session, because it's not that far away. Any final words?
Thank you.
All right, thank you everyone for your time today. We appreciate your participation. Look forward to seeing you at the next meeting.